Welcome, welcome, everybody. It's so good to be back on CPS and with this wonderful community. Steph and I missed the last 2 weeks because we just had a baby who's doing great, but unfortunately requested Steph's services right now, so she might join later, but it's going to be just us for now. And as always, looking for someone to present a case and 2 people to discuss with us. And by the way, anybody from the crew want to sort of co-facilitate with me, Anne-Marie, Charmine, anyone? Otherwise, I'm happy to try to go alone as well. Just let me know. So let me just pull up the chat. Thank you for the congratulations, everyone. No problem, Charmine. Thank you. So for the reflection this morning, I actually want to just share a big wish for the happiest of birthdays to Rabi Jiha. I don't know how old he's turning, but he's simultaneously infinitely old and wise and infinitely youthful and excited about a very long life ahead. But I think we all know him and love him and should wish him a very excellent birthday and year to come. One of the things I admire most about Rabi is just his constant sort of incremental drive to improve and humility in that, and also just his grace and kindness to everyone, including himself. And yesterday I was giving a talk to the residents on hyponatremia, which is a new conference talk I've given probably like 4 or 5 years in a row now. But yesterday's session, for whatever reason, was maybe like one of the worst talks I've ever given. It just did not go well. I was off, like it was on Zoom, but that's not like all talks are on Zoom now. That's not necessarily to blame entirely. It was just, it just didn't click. It didn't work. And then like, I was like very self-conscious about it not going well. And then it just got worse and worse. And hyponatremia is not the right topic to fumble with. You can very quickly, go off the deep end. So I was just thinking about, the processing the kind of bad feelings and guilt and stuff. And I was reminded of this passage I really like from a book I really like. The book is called Courage to Teach. And my program director in residency kept recommending it to me. And I just thought it was kind of a weird like title, right? Courage to Teach. I don't know. But the premise of the book, it might as well be called like Courage to Teach, Courage to Learn. But the premise of the book is basically that fear mediates so much of the phenomena and it permeates everything within like education at various levels. And the author, Parker Palmer, isn't a medical educator. I think he's a college English professor or something like that, history professor. But basically that so many learners are just, are afraid, are embarrassed, are scared. And every single teacher is also scared of their own role and of their teachers and stuff. And the examples brought will just resonate very much. And I think all of us can probably relate to a lot of this, especially in medicine. But the opening passage I'll just read to y'all because I just think it's so good. And I also think it shares the spirit of the clinical problem solvers and Rabi. I'm a teacher at heart, and there are moments in a classroom where I can hardly hold the joy. When my students and I discover uncharted territory to explore, when the pathway out of a thicket opens up before us, when our experience is illuminated by the lightning life of the mind, then teaching is the finest work I know. But at other moments, the classroom is so lifeless or painful or confused, and I'm so powerless to do anything about it, that my claim to be a teacher seems to be a transparent sham. Then the enemy is everywhere, in those students from some alien planet, in that subject I thought I knew, and in the personal pathology that keeps me earning my living this way. What a fool I was to imagine that I had mastered this occult art, harder to divine than tea leaves, and impossible for mortals to do even passably well. If you are a teacher who never has bad days, or who has them but does not care, this book is not for you. This book is for teachers who have had good days and bad, and whose bad days bring the suffering that comes only from something one loves. It is for teachers who refuse to harden their hearts because they love learners, learning, and the teaching life. When you love your work that much, and many teachers do, the only way to get out of trouble is to go deeper in. We must enter, not evade, the tangles of teaching so that we can understand them better and negotiate them with more grace, not only to guard our own spirits, but to also serve our students well. And I think that those same words could be said just about being in medicine as a learner, as a clinician, as a practitioner. Yeah, always kind of frequently reminded of those feelings, both on good days and bad. So thank you for humoring my reflections. And Azim was saying, please tell us you attached the Dr. Glaucom's second video. I did, and that's the only thing I said about hypernatremia. I was like, I don't agree with this video because hypernatremia can be taught in 30 seconds. Okay, so what do we have? Anusha, yay. We have a discussant and still waiting for a friend of Anusha's. Thank you, Sukriti. And then I heard through the grapevine that Raphael had a case if needed. Is that true, Raphael? Okay, sweet. So we'll just ask for any one other person to join Anusha to discuss with us, and we'll get on our way. Has anyone else read that book? I'm curious. Yes, Parker Palmer, The Courage to Teach. Thanks for sharing, Anne-Marie. Well, in that spirit, who wants to step in and focus on growth, and I promise you will also enjoy the challenge. Raphael's cases are always scintillating. All right, Keratin, let's do it. So I think the community knows both of y'all pretty well, but if you don't mind, introduce yourself anyway and say how things are today, and we'll get in.
Hello, so good morning, everyone. Myself, Kirtan. I am a final year medical student from Gujarat. It is in the western part of India. And I just participated yesterday in the neurology VMR. It was amazing. And I am looking forward to discuss the case today. I mean, the Anusha and both you are so brilliant. I hope I can live up to your standards.
Thanks, Kirtan. Great to hear your voice again.
Hello. Hi, everyone. This is Anusha Chidadla. I'm a PGY clinical medicine resident. I'm going to pursue my HEMONC fellowship in Kansas University. I have participated in CP Solver's VMR a couple of times in the past. I'm looking forward for this amazing case.
Thanks, Anusha. And Anne-Marie, do you want to pair up with Anusha, and I'll pair up with Kirtan, and we can have a full complement?
Yeah, that sounds great. I'm so excited to discuss with you, Anusha.
Awesome.
Okay, great.
Okay, Rafa, take us away.
So this is a case that I read on Human Gex this week. Very interesting, and it was created by Kevin Gurjiskin from Rush Medical College. So this is a patient that presents to the ER due to hypertension and episodic epigastric abdominal pain. I think it's a good place to stop.
Kirtan, why don't we go first? What do you think about when you hear this opening?
Yes, so very interesting. Now, whenever I talk about hypertension, I think that whether it is primary hypertension or the essential hypertension, or is it a secondary hypertension? And the host will give us idea about it. If the patient is relatively young with no family history of, let's say, hypercholesterolemia or other lipid disorders, or all the classic risk factors for atherosclerotic cardiovascular disease, then we have to think about the secondary causes of hypertension. For instance, the common place to start will be the endocrinologic causes, right? So things like hyperthyroidism, excess of growth hormones, excess of cortisol, all those things, then excess of adrenaline, so pheochromocytoma, stuff like that. And if it is indeed an older person, let's say above 60 years of age, then of course, secondary hypertension can occur in older person too, but we are more inclined toward the essential hypertension in that category in the older persons. And now if we throw in the second symptom, that is the episodic epigastric pain, it makes me wonder that what can cause episodic epigastric pain and how we can link that to the hypertension. Now, one common condition that can cause episodic epigastric pain may be the excessive secretion of the gastric acid, right? So we might be dealing with gastrinoma, or it could be simply peptic ulcer disease, probably H. pylori infestations, something like that. So that can be causing the episodic epigastric pain. Apart from that, another way to think about that is, what if the patient has evidence of atherosclerosis or narrowing in the mesenteric vessels? So what if the patient has got like mesenteric angina kind of thing? So that can present as episodic abdominal pain. And the mesenteric angina, if you combine that with hypertension, then you can get some rare causes like polyarteritis nodosa, fibromuscular dysplasia, which can simultaneously affect the renal vessels as well as the mesenteric vessels. And when they affect the renal vessels, it will cause hypertension because of excessive release of renin. And when it affects the mesenteric vessels, it can present as episodic abdominal pain. Apart from that, I will also like to see that the pain, what is the source of the pain? Are we localizing it to stomach? Are we localizing it to small intestine? Are we localizing it to the large intestine? Are the pancreas affected? So that can guide us that how to proceed further. And apart from that, there is one other thing that I would like to mention. Regarding endocrinopathy, we know that hyperparathyroidism can also sometimes present as hypertension. And hyperparathyroidism, as we discussed, I guess, few weeks back, that it can also increase the gastric acid secretion. And hyperparathyroidism also affects the motility of the intestines. So it can cause abdominal pain in that sense too. So all these things, cool things we can think about. And then, of course, medications, I would like to see whether the patient are taking any herbal supplements. Let's say patient is taking like licorice or something, which can cause the inhibition of 11-beta hydroxy dehydrogenase type 2 enzyme, so that can crank up the cortisol levels. So all these things, then of course we can think about what about renal artery stenosis? What if the patient has some pathology in the renal artery itself? So that can cause the hypertension. So all these things are there, but I guess now we should wait for more information and then we can proceed further. So Zavan, now can you help me? How should we proceed further?
I hope everybody listening in also learns from cases by reading various clinical problem-solving articles in medical journals, which is basically what we're doing, but in written form. And Kirtan, I was listening to you, and I was like, if Kirtan is ever like asked to be a discussant for one of these types of articles, he should just like take a voice recorder, like read the passage, talk into it, and that's the article. you talked about these problems in such a beautiful, thorough, and organized way, as usual. So thank you. I think you covered the epigastric pain, both with the kind of talking about the anatomic approach as well as possible overlaps with causes of secondary hypertension really beautifully. I think just kind of thinking in practical terms about what the hypertension is likely to represent in this scenario. I guess it was identified by the case writer as as prominent and part of the first aliquot. So maybe it's like a key part of this, but I feel like so often people come into the emergency department with whatever symptom, and just because of their pain, because of their anxiety, because of their sort of adrenergic hypersympathetic state of the moment, they're going to be a little bit hypertensive, sometimes very hypertensive. And that hypertension is not necessarily like has anything to do with the symptoms in terms of like causation. So I think that's just good to keep in mind, to consider all the possibilities of overlap, but also realize that most of the time it's just a secondary kind of paraphenomenon that is going to calm down, hopefully, once the patient's pain, anxiety, et cetera, subside a little bit. I think this is especially hard to overcome, though, in a lot of places in the world, including like my home country in Armenia. Like anytime any person in Armenia, young or old, like has any symptom, they check their blood pressure. And if the blood pressure is more than like 130/90, they're like, oh, my head hurts because my blood pressure is high. Oh, my stomach hurts because my blood pressure is high. Like it's always blamed for a variety of symptoms that, you know, it never actually causes in an acute setting. So I think it's very common in a lot of places for people to come to the doctor and say, hey, my blood pressure is high. And they're not even necessarily telling you like what the actual symptom was that bothered them and made them concerned, et cetera. So that's all I'll add in this opening. And as Kirtan said, we very, very much need more kind of context from age to background to more of the chronology of these symptoms of epigastric pain that made the patient come in.
So that's why I deliberately didn't say the age or the gender, because you guys can like put so much djecks in the middle of it, and it's so fascinating. So this is a 60-year-old female, and she presents to the ED for concerns of elevated blood pressure, peaking at 212/110. She reports for the past month, she has experienced episodic epigastric and left upper quadrant abdominal pain that radiates towards the left flank, and the pain is worse approximately 1 hour after eating. She has also experienced nausea, bloating, and urinary urgency. She also noted that her blood pressures were higher for the past 2 months, with blood pressures around 190/100. And prior to 2 months ago, her blood pressure was well controlled. And 2 weeks ago, on a virtual visit, her PCP started her on nitrofurantoin for a suspected UTI and increased her valsartan to 106 milligrams from 80 milligrams daily. And on the review of systems, this patient had unintentional 10 pounds weight loss over the past months. And she denies chest pain, shortness of breath, lower extremity swelling, headaches, bruising, changing bowel movements, and blood stools. When it comes to the past medical history, this patient had IgA, hyperlipidemia, and asthma, well controlled with albuterol, and hypertension, and positive hepatitis C antibody. Past surgical history, this patient had a cesarean delivery. When it comes to family history, her mother had colorectal cancer and her father liver cancer. And medications, she's on valsartan, furosemide, and albuterol. And social history, no tobacco, alcohol, or illicit drug use. And her last colonoscopy was 12 years ago, and it was normal. And that's the end of aliquot number 2, sorry.
Rafael, can you clarify? Sorry, you said she had IgA. Is it IgA deficiency? Is it IgA?
Iron deficiency anemia.
Oh, IDA. Ah, I see.
IgA. I'm sorry.
No problem. Thank you.
Okay. That's a lot of information. So 60-year-old female with, I would say like blood pressure, high blood pressure, right? Whenever I think about a female with high blood pressure, then it makes me think, is it a newly diagnosed blood pressure or hypertensive urgency that she's presenting with? Is it a uncontrolled, or is it because of non-compliance with medications? It doesn't seem like she was diagnosed with hypertension before from the past medical history. And she's not on any medications for a high blood pressure as well. So this is something which is undiagnosed in the past. So she might not be aware that she is hypertensive. And so the other thing is, I also wanted to know whether she has any flushing or whether she has any like any symptoms that are consistent with pheochromocytoma. Basically, it doesn't seem like she has any episodic headache, but I would like to know about any episodic flushing or sweating. But when I see a female patient with high blood pressure, then it makes me think about some rare causes like fibromuscular dysplasia, or it may just be an undiagnosed, increased valsartan. Okay, so she was already having a history of hypertension. Yes.
Exactly, it was well controlled up to 2 months ago.
Okay, sorry, I missed that. Okay. So then we should ask more about like whether she's compliant with her medications or not. And we also have to think about differentials like basically fibromuscular dysplasia, because in patients who have renal artery stenosis and fibromuscular dysplasia, then patients who are on ACE inhibitors can have hypertensive urgency kind of presentation as well. So coming to this epigastric pain and left upper quadrant pain that's radiating to the left flank, as you know, like in the abdominal pathology or abdominal pain, you always have to localize the pain. So this is mostly in the epigastric pain and also left upper quadrant pain. It makes me think, is it related to the spleen, or is it related to the kidney because it's in the left flank? Like Ketan said, there is always a chance that it might be some kind of a atherosclerotic process, or it may be like an embolic phenomenon from mesenteric ischemia as well, given the epigastric pain. Or the left flank pain makes me think, is it something related to the kidneys, or is it something related to the adrenal gland, which is causing this problem? I'm honestly not sure what might be the cause for the left flank pain, but I'm going to blame it on the kidneys and adrenal glands for now, given hypertension and its coexistence with this left flank pain. And also we know that hyperaldosteronism or adrenal adenomas, which are functional, can also cause this kind of presentation with hypertensive urgency, and also pheochromocytomas can also cause this. So the next point is she was having urinary urgency. That's the reason they thought she might have an UTI. So is she having recurrent UTIs, or is this something new UTI? Because patients with recurrent UTI sometimes may have kidney problems, and that might be the reason for them to have hypertension as well. Any kidney problems will lead to hypertension in these patients. So we'll know whether her creatinine is at baseline or that is it increased. And the next thing is unintentional 10 lb weight loss.
So whenever I think about weight loss, then we have to always look at her baseline weight, and this is over 1 month. So that means it's very significant. And unintentional weight loss. So it makes me think of cancer. It makes me think of something malignancy going on somewhere, but we don't have a clear source of what might be the malignancy here. So given the symptoms mostly tend to be in the abdomen, it may be a GI malignancy, we don't know, or it may be a malignancy in the adrenal gland itself, or it may be a malignancy in the kidney itself. But she doesn't have any hematuria or anything to think it might be renal cell cancer or something like that, which can present as hypertension and at the same time unintentional weight loss too. And given past medical history, she has hepatitis C antibody, which is positive. So in some patients with cryoglobulinemia or vasculitis like PAN, those can also present with hypertension. And at the same time, those can also present with some other findings like arthritis and some rash, but we didn't see anything like that as of now. And the other thing is PAN patients can have epigastric pain, like if the mesenteric vessels are involved. So I'm not entirely sure what the patient is taking the Lasix for, the furosemide for, so we can ask Rafa about that. So right now we have a lot of differentials on board. So I'm mostly leaning towards the hypertensive emergency and relating it to the left upper quadrant pain and left flank pain. Maybe it's something related to adrenal glands, or maybe it's something related to the kidneys, or maybe it's related to the hep C antibodies like the cryoglobulinemia and polyarthritis nodosa kind of stuff. And the unintentional weight loss makes me think maybe there might be some undiagnosed underlying.
Não posso falar agora não, tô ocupada. Oi. Mãe. Eu já comi, não precisa não. Tô ocupada na reunião.
Given the history of colorectal cancer and liver cancer in the family and her unintentional weight loss, she might be having some occult malignancy that's going on, which is undiagnosed for now. Maybe a renal cell cancer, which might present in the same way as well. Or maybe a liver cancer too. So a lot of differentials for now. We need more data.
Anusha, that was such a wonderful and comprehensive discussion. I did want to say that I do slightly remember this case, but I feel fine generally talking about it, but I am familiar with some of the case. So I thought what you did really well was kind of highlighting hypertension is a very common problem. And we're first going to be thinking about the more common thinking in the base rate about primary hypertension. But here you can't forget about secondary causes, especially it sounds like it was really well controlled and all of a sudden it's been increasing, and thinking about could there be some sort of etiology at play that's causing the hypertension, and then also saying like, is the hypertension a separate problem? Is it related due to like a pain, anxiety mechanism, or is there some sort of unifying diagnosis at play here? And you did such a great job of going through the differential, thinking about primary, thinking about just factors that affect blood pressure, like being able to take medications, things like that, having access to them. And then also saying, but let's not forget about secondary causes that could be aldosterone, renin related, could be related to the kidney, whether blood flow through the kidney, such as renal artery stenosis, fibromuscular dysplasia, which I think about generally in younger patients, but could certainly present atypically. And then also thinking about a glomerular process, especially with the history of hep C, or a vasculitic process that could also lead to hypertension. And then thinking about, is there some sort of compressive process at play that's activating the system, or some sort of cancer that's, secreting, leading to the hypertension. And then also thinking about things like thyroid, hyperparathyroid, things like that. And so we're kind of going to be keeping the secondary causes in the back of our mind because we definitely have some concerning factors here. And then I loved how you connected the weight loss and said, you know, like with this weight loss and some of these abdominal symptoms in a 60-year-old patient, this is really concerning for malignancy. There's a family history at play. Definitely pain after eating is the more common abdominal pain. We were talking on Monday about a case where the pain actually got better with eating. And I had forgotten, I was like, I think it's like peptic ulcer disease. And I was reminded that it was a duodenal ulcer where you can sometimes see that it gets better with eating. But most conditions, the pain will worsen with eating because you've got the blood flow to the gut, you've got the secretion of pancreatic enzymes, the gallbladder contracting, all those factors at play that a lot of times will lead to worsening with eating. And then I always am a little skeptical of urinary tract infections. It's always a diagnosis. I'm like, I'm not sure if this diagnosis is actually correct, especially one that was on a telehealth visit. And so I think we have to figure out like why the patient thought they had a urinary tract infection and if that was truly the correct diagnosis here, or maybe some of the symptoms that were experienced, like sometimes people say, oh, I have dark urine, I think I have a urinary tract infection, but that can be a sign of hematuria, breakdown of red blood cells, elevated like bilirubin in the urine, a lot of different things. And so really getting to the bottom of what this suspected urinary tract infection was, and maybe if that signal actually for a whole different process at play here. So great job, Anusha. I'm excited to hear more.
Okay, so physical exam. The temperature is 36.7. The heart rate is 81, respiratory rate 15. The blood pressure was 219 over 112. And she's saturating 100% on room air. Near exam, this patient is awake, alert, and oriented to name, place, and time. Cranial nerves from 2 to 12 are intact. And motor strength is 5 out of 5 in all extremities, and there are no focal motor or sensory deficits. When it comes to skin, there are no bruising, no petechiae, no bleeding, no jaundice or rashes. Abdominal exam, non-tender to superficial and deep palpation. No suprapubic abdominal tenderness, no costovertebral angle tenderness, no pulsatile masses palpated, and no hepatosplenomegaly. Her HEENG exam, no icteric changes or conjunctival pallor, no cervical or supraclavicular lymphadenopathy. In general exam, this patient appears comfortable, sitting in bed, and no acute distress. And that's the end of the physical exam.
Raphael, is there a lot more like just lab and imaging data? Do you want to include anything else with this aliquot, or is this a good spot to stop?
I can give you the labs if you want, for the sake of time, I guess.
I mean, yeah, maybe just the basic labs.
Okay.
Or just whatever you think, Raphael.
Yeah, I think it's a good place to continue because there are 3 more aliquots.
Yeah.
When it comes to, okay, so the labs. The white blood count was 6.04. The hemoglobin was 11.2, and the MCV was 9.1. And the platelets were 258. And basic metabolic panel, her sodium was 140. Her potassium was 4. Chloride 107. Bicarb 23. BUN 14. Creatinine 0.87. And her glucose was 83. Her AST was 11, ALT also 11, alk-phos 74, total bilirubin 0.4, total protein 7, and albumin 3.4. And her RNR was 1.02. And her urinalysis were negative nitrate and leukoesterase, no white blood count, no RBCs or bacteria. And that's the end of the aliquot.
Thank you, Rafael. Kirtan, a lot of data, but I don't know if there's a lot of positives. What stands out to you and what, yeah.
Yes, I totally agree with you. And now we have to build upon what Anusha and Anne discussed. That first, my concern is that the patient is going into a hypertensive urgency, emergency kind of state. The BP is shooting up above 200. So I would immediately like to make sure that patient doesn't enter the state of hypertensive encephalopathy and patient doesn't develop any sort of papilledema, retinal hemorrhages. So that's our primary concern. Now we have to control the damage that this hypertension can cause, and then we can look at the possible causes. And I totally agree with you, Seven, that we haven't got much positives from the examination so far. But I can just point out a few things that talking about the fact that the pain was radiating from the lower upper quadrant to the lower flank, we can think about what if the patient has little bit of nephrolithiasis kind of stuff. And if you add the urgency to it, then our initial hypothesis that hypercalcemia might be somewhere in the mix kind of makes sense, because we know that hypercalcemia and hypokalemia can sometimes blunt the ADH receptors, and that can cause polyuria, polydipsia kind of thing. So in case we are dealing with high PTH state, then all the rest of the physical examination will be normal, and we haven't yet got the calcium levels. So maybe calcium levels are high, we don't know. But then how to figure out the weight loss? The classically hyperparathyroidism won't cause the weight loss. But what if we are dealing with hypercalcemia of malignancy kind of stuff? So for example, PTH RP is being produced by some malignant tumor, as the Anusha mentioned. That what if there is a tumor somewhere? What if there is a lymphoma which is producing excess of calcium? So that can tie in the weight loss. And apart from that, whenever I see the worsening of hypertension, in the first aliquot when we discussed, we didn't have the idea that the patient already has hypertension. Now we have the evidence that the patient has hypertension and it has suddenly worsened. So what can potentially cause the worsening of hypertension? So basically, when I was in my third year of medical school, one of our professors taught us that, of course, you focus on renal artery stenosis, but you also have to focus on the glomerular causes, as the Anne mentioned. So if it is indeed, let's say, cryoglobulinemia kind of stuff, or the glomerular injury, or the renal parenchymal injury, then that can cause the hypertension. But then the urinalysis so far has been unrevealing. I mean, there has been no evidence of RBC cast or WBC cast. So that argues against the glomerular pathology. So that again leaves us with either pre-renal pathology or some post-renal compression. So like ureter is being compressed, probably bladder is being compressed, or renal pelvis is being compressed by some retroperitoneal mass or something like that. But yeah, so that's all I have got. I mean, I don't know how to proceed further because so far nothing has come up in the examination or labs. So let's see how it proceeds.
Kirtan, what would I think calcium is very much indicated, absolutely. What would your next diagnostic step be?
Yes, so of course I would like to get the calcium. I would like to get the phosphorus levels. I would like to get the PTH levels. I would like to get the vitamin D levels, PTH RP levels, and probably just to make sure in the urinalysis, I would like to get metanephrine levels. I would like to get the serum morning cortisol levels. I mean, in the physical examination, we do not have evidence of weight gain or the bruises or the classic electrolyte disturbances. But if we don't have any evidence, then maybe we can, just to make sure that since it is 200, it has crossed the 200, and very few causes can cause the hypertension that high. So just to make sure that it is not pheochromocytoma, and pheochromocytoma can definitely cause the weight loss. So we should get serum metanephrines and urinary 24-hour metanephrines too.
Good. What about any imaging? Would you be interested in any imaging at this stage?
Yes, definitely. I would like to get probably USG of abdomen, USG of the pelvis, just to make sure that any mass is not there. And then if that is unrevealing, then maybe we can proceed to CT scan of the abdomen.
Yeah, I think so. And I would actually probably go straight to the CT scan just for increased sensitivity. I mean, it depends on, you know, where you operate and what's available. You know, in some places, your ultrasound quality is actually going to be better, and CT might be less available. In the US, in these settings, you know, your best bet is probably going to be cross-sectional imaging with a CAT scan to both assess for things like nephrolithiasis, which you mentioned, but also for any masses that could be kind of causing local involvement there, as well as for kind of early vascular imaging, right? And the harder decision is like whether to protocol the CT scan just with normal intravenous contrast or to try to do an angiogram. Because the one thing on exam that stands out to me is that the belly's not tender, right? The episodic abdominal pain was very prominent, it seemed, on the history, but there's no tenderness at all there. So if this was pancreatitis, for example, right? First of all, that would be a weird time course, but like it should be tender, right? Whereas the fact that every time the patient eats, it worsens, but it doesn't hurt to press at all, that kind of prioritizes kind of vascular process and possible mesenteric ischemia a little bit more. Although, you know, like biliary colic, for example, you know, in between episodes, in between attacks, you're also going to be non-tender, right? So, but the fact that this is more kind of trending to the left side, you know, pushes you a little bit away from that. Yeah, I mean, the UA is very reassuring for the glomerulus, as you mentioned, and then we're not really getting a lot of, you know, the anemia, normocytic anemia is non-specific, right? I think it's worth working up with, you know, sort of reestablishing her current iron states, checking a B12, probably at this point with all of this going on, maybe thinking about an SPEP and looking at a smear. But the fact that she's lost weight, right, just implies some degree of systemic inflammation and or malnutrition at this point. So the anemia isn't going to be super discriminatory in terms of explaining everything else involved. So let's move on and see where we go next.
Zavin, can I ask you a question about like how you would approach this? Does the time frame kind of make things like aortic dissection and things less likely on kind of how you're approaching this, or how would you incorporate the time frame into thinking about vascular phenomenon?
You know, aortic dissection is so no. I think even with you know. Okay, so short answer is no. It doesn't dissuade me from thinking about vascular causes, including even what you think of as like acute life-threatening vascular causes, because aortic dissections can be like all at once, rip-roaring, tearing, horrible pain, right? Patient coming in like a crisis, and it all started 20 minutes ago. Or you can actually dissect more slowly and subacutely and chronically. A lot of dissections are just seen incidentally on imaging, and they're completely asymptomatic. So whether it's an atherosclerotic process that instigates the dissection, or one way that the hypertension could be involved is, what if the hypertension was just essential hypertension, right? Maybe it wasn't intermittently as well controlled as you would hope, and it was the risk factor for an aortic dissection, that now there's a flap, there's a false lumen, there's a relative, stenosis, including in some of the aortic branches, or maybe the dissection was in the mesenteric vessels themselves. And now there's sort of like a stable stenosis that is resulting in a phenotype of like stable angina of basically just postprandial pain, but not intervening pain. So I think it's still on a differential, and part of why I think getting imaging early would be indicated.
So I'm gonna give all the rest of the information until the final GX. So imaging, the CT chest showed a borderline enlarged left supraclavicular lymph node, and the CT of the abdomen and the pelvis showed a well-defined soft tissue density at the porta hepatitis, causing severe narrowing of the portal vein confluence that extends medially to encase the celiac and the superior mesenteric artery origins. And MRI of the abdomen without a contrast showed a large soft tissue mass lesion centered within the porta hepatatis and superior pancreatic head with encasement of multiple vascular structures. And her final labs were a CEA of 2, which is lower than normal, an AFP of 4.5, which is normal, and a CA19-9 of 195, which is high. The upper normal limit is 35. And that's the end of the aliquots.
So whenever I see left supraclavicular lymph node or any lymph node enlargement, first thing is like whether it's it's secondary to infection. Is it reactive to something, or is it secondary to malignancy and mets from somewhere else? And the most common site of left supraclavicular lymph node enlargement, like mets from somewhere else, is like lung, or it can be secondary to testicular in male. And here it looks like some intra-abdominal pathology. So the CT abdomen and pelvis has shown some soft tissue density in the periportal severe narrowing of the portal vein. So it likely might be, the soft tissue might be a lymph node. We don't know yet. And the fact that she's having epigastric abdominal pain, and this soft tissue density is encasing on the celiac and SMA origins, it likely is compressing the superior mesenteric artery, and that's why this patient is having epigastric pain. Like Dr. Javin said, so basically this patient does not have any abdominal tenderness. So in a patient with mesenteric ischemia, patient does not have any like objective findings like abdominal tenderness or anything. They have subjective findings like pain and pain with eating, those kind of symptoms. So it makes sense that this soft tissue density, which might be a lymph node or which might be a separate pathology, or it might be arising from the liver itself, or it might be arising from the pancreas, given the CA19-9 is elevated, because CA19-9 is elevated in patients who have pancreatic pathology, like pancreatic carcinomas, or they can be also elevated in gallbladder pathology at times. In patients who has like cholangiocarcinoma, CA19-9 can be elevated as well. So the mesenteric ischemia and also the epigastric pain are correlated because this mass is compressing on the SMA organs and celiac organs. Coming to the MRI, the large soft tissue mass lesion within the portohepatic and suprapancreatic head. And given the fact that the CA19-9 is elevated, it makes me think about some pancreatic malignancy. And as you know, like pancreatic malignancies are pretty aggressive and they can spread very easily and in a matter of like less than few months. And this patient is having symptoms only for the last 2 months. And her unintentional weight loss in the last 1 month make me think this might be a pancreatic malignancy in the setting of CA19-9 elevation and there's imaging findings. And honestly, I'm not sure whether to relate this blood pressure, the hypertensive urgency with pancreatic malignancy. I don't know how I can relate that to the pancreatic malignancy. I don't know if there is any paraneoplastic syndrome that's causing her to have high blood pressure, or is it just from her being in pain, that's making her to be having more high blood pressure. Like pain itself can be a cause, pain and anxiety itself can be a cause for patient to have very high blood pressure itself. So I will leave it up to that.
Awesome. Great discussion, Anusha. I like how you kind of tried to fit all the pieces of the puzzle together. One thing I always like to remember about tumor markers is that they should be taken in the correct context. Really, the context that most of them are meant for are for monitoring response to malignancy. And so sometimes you can see like an elevated CA-125, which is associated with ovarian cancer, but like in TB peritonitis or endometriosis, things like that. So I think it's always important when we have these markers to make sure that we understand them in the right clinical context and realize elevated marker does not necessarily, equate to malignancy, but they're very helpful to monitor. But I agree with you with the kind of everything that we have together. So we have this soft tissue density and narrowing of the portal vein. It seems like it would probably be kind of in the pancreatic tail and maybe like with metastasis through the lymph nodes. If it was in the head, I would maybe expect a little bit more elevation, like in obstructive jaundice, things like that, and that maybe it metastasized from there. We have to be thinking about, could it be a gastric cancer? There's a little bit of anemia there, but just where it is in the elevated CA-199 seems less consistent. And then like in a female, I'm also thinking about, could this be some sort of GU cancer or something like that? But just the location of it, if it was a GU cancer, I'd expect some probably peritoneal involvement as well. And I'm, not seeing it. So it does seem like it's probably pancreatic, but tissue is going to be the issue. It's going to drive further management. It could be a non-cancerous cause, but in this case, kind of considering the time course, lack of exposures to infectious etiologies, I think would be driving it. I'm very much thinking cancer. And then, also like with the weight loss and everything else. So I completely agree. It's probably cancer. We need to get a tissue to confirm it. And then I'm wondering if perhaps the hypertension is because of the encasement of the blood vessels that are basically causing the body to think it's not getting enough perfusion and increasing the hypertension. So that would be one potential way to kind of connect everything together. Does anyone else have any other thoughts?
I think that was great, y'all. Raphael, you want to tell us what happened?
Sure, an incredible discussion as usual. So this patient underwent endoscopy ultrasound with final needle biopsy that confirmed pancreatic adenocarcinoma as the final diagnosis. This elevated blood pressure was felt to be secondary to the arterial encasement by the tumor, and her tumor was revealed by the GI tumor bar and was determined to be non-resectable, and she was enrolled in the PANOVA-3 clinical trial.
Thanks, Raphael. Who's Sukriti? You're doing the teaching points, right? You'll bring us home in a second. I just wanted to kind of share my quick reflection that in thinking about kind of syndromes that seem like vascular, right? And especially with a more chronic kind of stable angina vascular phenomenon, whether that's, mesenteric like this, or if this was like a leg claudication or something like that, I realized that, I don't often enough consider like extrinsic compression as a mechanism of arterial insufficiency, no matter which vascular bed you're talking about, like as was the case here. So that was just kind of a comment on my thinking and a little bit of a gap there. But Sukriti, why don't you just summarize some of the teaching points for us, and we'll end the hour.
Thanks everyone. So this was an amazing case. We went through a lot of schemas for symptoms. And so we began with this hypertension, and right off the bat, we learned from Zavin that it's important to identify whether the hypertension is true and related to the clinical syndrome, or sort of a secondary phenomena associated with just being ill or anxiety of coming to the clinic or hospital. And so we approach this in a stepwise approach, always thinking of base rate first and what's more common. So base rate favors primary hypertension. And in a person with primary hypertension, it's important to think about the social factors that may influence his or her disease, such as compliance, access to medication, diet, or any changes in the environment. And then in this case, what really prompted a rethinking of what was happening in this patient was the sudden change in the course of the disease, which made us think about what could be the secondary causes of hypertension. And we went through the illness script with Anne-Marie, thinking about the kidney, endocrinopathies, medications, drugs, and the thorax. There's an amazing schema on the Clinical Problem Solvers website, so I won't go through all the etiologies. Then we also learned from Zavin that the absence of the acute worsening of hypertension shouldn't dissuade us from considering life-threatening etiologies, such as dissection. So dissection may actually lead to pseudoaneurysm that may present as a mesenteric angina. So this could be a potential pitfall when evaluating chronic hypertension. And then we learned from Kirtan, asking who is this patient is really important because it can help prioritize the differential for hypertension. So considering what is the family history, what is the age of the patient, what kind of medications is this patient taking, and what are some other pre-existing diseases. And then we went on to discuss the episodic epigastric abdominal pain. And we learned from Kirtan and Anusha, the first thing that we do is to think about this anatomically. So thinking about going from outside to inside, the musculoskeletal system, then the viscera, and then the vasculature. And something that we've learned from Rabi is that eating is the stress test of the GI system. So it's important in a patient with episodic epigastric pain to ask about its relation to eating. And if there was a positive correlation, to think about pathologies of the pancreas, the hepatobiliary system, the upper GI, the abdominal wall, and the vasculature. And another important part of this case was the absence of tenderness on the physical exam. And this just highlights how sometimes even a negative exam can be so helpful in prioritizing your differential, because here it helped us prioritize a vascular or a hepatobiliary cause. And then we learned from Anne-Marie, just important to revisit how a diagnosis was made in the past before incorporating it into your problem representation, such as the UTI, suspected UTI here, because sometimes this may falsely alter how you frame the clinical syndrome. And finally, we also learned that it's important to understand the context in which we're thinking about tumor markers. So they're definitely helpful in monitoring the response to malignancy, but not necessarily in diagnosing one. So it was an awesome case. Thank you all so much.
Thank you, everybody. Thanks, Sukriti. That was a great recap. And have a great week, and enjoy the rest of your day. Bye.